Hi, I'm David Levine. I'm co-chair of Science Writers in New York. My other co-chair, Joseph Bonner, is working the video, and we also added closed captioning at someone's request last week. So I hope that helps people. Anyway, my guest tonight is John Moore. It's the second time he's been with us. He's a professor of microbiology and immunology at Weill Cornell Medicine. He is known for his research on HIV/AIDS. He previously worked at the Aaron Diamond AIDS Research Center. He received his bachelor's degree, master's degree, master of philosophy, and PhD degrees from Cambridge University. So he does have an English accent. He's been at Weill Cornell since 2000. The focus has been research on HIV-1 envelope glycoproteins. He directs several National Institute of Health grants. And and tonight we're going to talk about viral variants. So Dr. Moore, would you like to come on screen and say hello?
Good evening, David. Joe, thanks for having me again. I look forward to an interesting Q&A.
Okay, so if you have a question for Dr. Moore, please put it in the Q&A box, not the chat box, and we will get to all your questions. So you wrote a paper in JAMA. It's published March 4th. It says approaches for the optimal use of different COVID-19 vaccines, issues of viral variants and vaccine efficacy. So what prompted you to write that?
The need to plan. I was having multiple conversations with colleagues about what might transpire in the future, what strategies we might consider, whether the variants that we all know are now circulating, whether they are going to be a problem for vaccine efficacy, what we might do about it. There was a particular theme that's emerged since vaccines started to be rolled out in hospitals, that hospitals have set up their own cohorts of staff who are obviously vaccinated on site and can be persuaded to give blood samples. And the theme that's emerged is that convalescent people who had COVID last year and who've recovered since then, are responding very strongly to only a single dose of the mRNA vaccines. And there's a strong argument now that that is sufficient to give them maximal immunity, and they don't need a second dose. And the second dose in some cases can be fairly fierce for side effects in younger convalescents. Plus, it will be a great deal of dose saving if convalescents don't need two doses rather than one to achieve the same level of particularly antibody-mediated immunity. So that's emerged from research in hospitals since essentially January, when the rollout kicked into gear. I believe the FDA is now considering this very seriously. And another theme that I touched upon is whether later in the year we can look at combinations of vaccines, which is not appropriate at the moment. It's not been tested, it's not FDA approved, but there's a certain amount of there's a lot of precedent for this in the HIV vaccine field, where different vaccine designs are routinely combined in clinical trials with no safety issues and perhaps marginal benefits in the HIV context, but there could be benefits to the COVID context. So that, I think, is a theme that we will see explored clinically in the coming months, and perhaps finish up doing a heterologous vaccination regimen towards the end of the year. That's certainly a plausible theme.
Okay, so for people who have not had COVID, they still recommend the two-dose regimens, right?
Absolutely. What I was talking about was only for convalescent patients. The US policy on two-dose vaccination for the mRNAs is spot on. I co-wrote another editorial recently with Celine Gounder and Lou Borio, in which we strongly argued that the policy is right and why we thought it was right, and will continue. It's not the same in the UK, but that's another issue for the Brits to figure out. I think it's the wrong policy, but it's nothing we can do anything about here.
So what are the variants in the United States right now, and which ones are you concerned about?
Right, so the CDC has a new website. I think it's fairly new. I only came across it this week, and I haven't seen anyone else who's seen it. It's called SARS-CoV-2 Variant Classifications and Definitions. And I think it's quite helpful, and I'm sure it will get updated regularly, and it's exactly what CDC should be doing to help people. And it talks about 3 variant classifications: variants of interest, variants of concern, and variants of high consequence. It does not have a category for variants of mass panic, which is a very good thing because the public has become a little bit freaked out from some of the media reports. Now, the CDC classifications has 0 viruses in variants of high consequence, and I don't know what their criteria will be from going from concern to high consequence, but they're not there yet. The variants of concern that they list are B117, which arose in the UK, so it's commonly called a UK variant. Shouldn't be using these terms, but we all do. B1351, that was first seen in South Africa. P1, which came out of Brazil, and B1427 and B1429, which are very similar and were both circulating on the West Coast, sometimes called the California variant. Now, I looked and saw and noted with interest that the so-called New York variant, B1526, is not considered a variant of concern, it's a variant of interest. That classification might change because its properties are actually quite similar to some of the variants of concern. So I think that's a preliminary classification, and it will get upgraded to a higher degree of severity. So that's what the CDC is currently classing, these 4 different lineages as variants of concern, and the 526 New York variant as a variant of interest, along with another Brazil variant that I don't think is present in the States. So that's where we stand. And they have different properties, and I think it's worth discussing the different properties because they're not all the same. So B117, which is predicted to be a dominant variant in the USA in the near future, it's spreading quite rapidly. That is not an antibody-resistant virus. Its difference in antibody sensitivity compared to last year's viruses is minimal. So we don't think it's going to be a problem for vaccination in any way, shape, or form. It's not going to dramatically change reinfection rates in recovered convalescent patients. It is more transmissible, which is why it's spreading. And there are 2 studies out of the UK now that show that it is more lethal by approximately 60%. So it's definitely something to avoid. So it's a concerning virus, but it's not antibody resistant. The Californian variants, B1427 and B1429, they also are only minimally antibody resistant. They don't look like they're antibody escape mutants. They're also more transmissible. We don't have as much information on the relative transmissibility, and there's no information yet on whether they're more lethal. So they're kind of cousins of B117. The others, B1351, P1, and the New York variants, they're more of a concern because they have a degree of antibody resistance. So they might have some ability to break through vaccine protection in some people. They have more ability to reinfect convalescent people because they escape from the antibodies that convalescent people have. So they're more troubling to us. But again, they're not variants of mass panic, they're variants of concern. Of them, the South African B1351 has the greatest degree of antibody resistance. So the others are there, but not as profound. P1 seems somewhere between wild type and the Brazilian variant. And the New York, we don't have as much information on yet, but it's probably similar to the Brazilian. So they have a degree of antibody resistance, and in all probability, they arose in infected people as an escape mutation from the antibodies that those people had. So when you have virus replicating in the presence of immune responses, if the immune response is very weak, the virus doesn't notice and doesn't mutate. If the immune response is very strong, the virus can't replicate and mutate. The concerning level is somewhere in between. So if you have an intermediate antibody response, that puts selection pressure on the virus, and the virus mutates to escape it. And then those mutations may also, in some cases, give a selective transmission advantage. So it'll spread and it's antibody resistant to a degree. And again, it's all a numbers game. These are not completely resistant. These have reductions in antibody sensitivity in lab assays. And we're not yet sure the extent to which that translates into reductions in vaccine efficacy. We do know, because it's a clinical trial result, that the Oxford AstraZeneca vaccine completely failed in South Africa against B1351. So, but that is not the strongest vaccine around. So even if B1351 spread widely in the States, which it's not doing yet, the Pfizer and Moderna, and if licensed, Novavax vaccines are strong enough, we think, to cope with it, providing you've had 2 doses. So there's a lot of attention played on these variants. There's a lot of papers come out. There's a lot of studies being done in a lot of labs. And every day another preprint comes out that advances our knowledge. So they're active areas of research.
So if people had a choice between vaccines, which ones should they get?
Whichever one is available that the FDA has approved. There really is,
Okay.
all of them are capable of preventing disease and death, which is the prime goal.
Okay.
The J&J vaccine is less effective at preventing mild infections, which people don't die of. So prevention against disease and death is the strongest criterion. That's also true in UK studies of the Novavax vaccine. It's strongly protective against disease and death, and also infection. It's on a par with Pfizer and Moderna. Oxford AstraZeneca appears to be on a par with J&J, but requires 2 doses, not 1. And that has become highly controversial in Europe and in the USA. Every day there seems to be another Oxford AstraZeneca controversy. And the concern now is that public trust is so damaged, and trust within the government is so damaged that even if it's approved, it may never be used.
Okay, I just want to stress, if you have a question, I'm only going to read questions, so please don't raise your hand, and just write the question in the Q&A box. Thank you. So I've also, we've read that Moderna is studying a booster shot against different variants. They're also testing it in children. I assume Pfizer is going to also look at that too.
They all are. I mean, all of the companies are redesigning, and the redesign strategy is based on the South African B1351 variant, which is, as I said, the greatest concern for vaccine efficacy. And there's quite a technical study out of South Africa last week that shows that antibodies induced in South Africans infected with that virus have a decent degree of cross-reactivity with B117 and the standard strains that circulate last year. So that seems a good choice, but it needs tested experimentally. And it's not a given when you give a 3rd shot, which is what it would be. It's not a given that you actually will generate antibodies to the new vaccine variant. There's something called original antigenic sin that we're aware of a long time, and it's resurfacing. When you boost with a variant vaccine, what you generally tend to do is boost the existing antibody response more than you generate a new one. So that's going to have to be tested out. That's exactly why you do clinical trials and analyze what the outcome is.
Okay, so you and I are both in New York City. So should we be concerned about catching the New York City variant?
Well, you're no more likely to catch it if you behave appropriately and responsibly, and wear your mask and don't do crazy things, and just generally respect your environment. I mean, these variants are transmitted by exactly the same way. They're just slightly better at it. And it seems there was an interesting study on the B117 as to why it's more transmissible. It came out of a UK group about 2 weeks ago. And it seems that people infected with that virus produce virus in their nose and throat for a longer period. So they produce about the same amount, but instead of doing it peak amounts for 2 or 3 days, they're doing it for over a week. So they have greater chance of spreading virus to someone else. So if you're not coming into contact with people who are viremic by knowledge, or if they know, or pre-symptomatic, you're not going to get it. It's not like you're more vulnerable. There are the people infected with it are shedding more virus. So that's a sort of different dynamic than being more at risk because of the virus is more likely to infect you. You're just more likely to come across it. And as I said, B117 is not thought to be a problem for vaccines.
Okay. You also talked about that between the first dose of the vaccine and the second, you should be very careful.
Yeah, you're not vaccinated. There is a degree of protection after the first dose. There's nothing for 12 to 14 days. There's some terrific real world studies come out of Israel. I think there's one out of the UK now, but the Israel one has got a very, very revealing graph on showing the infections in the placebo and the vaccine groups. And if you start off at day 0, the day of the first injection, those curves are absolutely superimposable until about day 12, and then they diverge. And then that means you get less infections in the vaccine group than the placebo. But for 12 days, there's absolutely no difference. Then from day 12 onwards, you get gradually increasing degree of protection. And after the end of the first dose period, it's around 50%. But the second dose takes it up to 95. So that's worth having. You are only partly protected in that interdose period.
So you have a false sense of, some people have a false sense of security after the first.
And people are already getting infected in that interdose period because they're not listening to the message, which is you're not vaccinated until the second dose.
I know someone who got COVID, diagnosis the second day after his second dose.
Yeah, and well, it takes, after the second dose, the antibody response is boosted, and it takes 7 to 10 days to reach a maximum level. So, you know, for approximately 10 days after the second dose, you're not fully protected. For J&J, the official period is 2 weeks, and some people think it really should be more like 4. You know, 2 to 4 weeks after your dose before you're fully protected. These things don't kick in overnight. Immune responses take time to generate. So you have to respect the process.
So I want to go to some people's questions. Okay, so what's being done to track real world effectiveness of vaccines? And are studies being designed that will provide insight into the different variants?
Sorry, I'm trying to, is this question on the screen? I've just pulled up the question.
No, it's not. It was sent in by a reader, so I'll repeat it. What's being done to track real world effectiveness of the vaccines? And are studies being designed that will provide insight into real world effectiveness against the different variants? I imagine the latter is particularly challenging.
The latter is challenging because it's more difficult, but vaccine breakthrough cases in hospitals are going to be studied. There will be some. There was 3 reported in Hawaii last week. There was a story in the New York Times today, a very good story by Denise Grady that talks about a New York physician who got infected. Firstly, 95% is not 100%. So there will be people. And if you take a cohort of 100 people and vaccinate them, their antibody responses will vary over 100-fold range. It's not everyone responds in exactly the same way. Some people are very strong responders and some people are very weak responders. So people who don't respond well because of the natural genetic makeup are at more risk than people who respond strongly. So there will always be people who are infected despite vaccination. And then you have the variants to throw in, which is possibly increase it, the breakthrough rate, possibly. Now, to detect the variants, you have to have the patients, then you have to sequence them, then you have to analyze them. You know, it can be done, and it is done in leading hospitals, but it takes time. And the New York City, New York State are tracking variant infections. It's part of the job. The Department of Health at state and city level, and in the other big cities, are tracking in as close to real time as possible what's going on in our cities. So they have databases, and it's up to them as to when they make them public. I don't know the procedure there. So There
So
are,
what,
sorry, I just meant the Israelis have a huge centralized national system, which we don't have. We operate on states and city levels. And their very large study, in fact, the first 500,000 vaccinees tracked vaccine efficacy in real time. And the British National Health Service is doing the same thing. I think there's a couple of papers out. I haven't studied them in as much detail. But the Israeli data absolutely supports the phase 3 clinical trial data for Pfizer.
okay, so do you want to open up the Q&A box, and you can look at the questions? So the first one, is there any data on each vaccine's effect on transmissibility?
Increasingly, there is evidence that the vaccines prevent infection and not just symptomatic disease. The clinical trial endpoints were symptomatic disease, but since then, the kind of real world studies that I'm talking to, including the Israeli Pfizer study, shows there are reductions in infections, and that's also being seen in the UK. I'm sure it'll be seen here. So yes, these vaccines are preventing transmission. We don't have the data to say it's 100% or anything along those lines. I think I've not seen anything on J&J. Pfizer and Moderna are so similar that data from one will apply to the other. So yes, we're seeing effects on transmission.
Okay, so the next one is, what do you think of the CDC's policy allowing vaccinated people to meet indoors without masks and social distancing, given the variants?
Well, they're guidelines, they're sensible, they've been well crafted. The variants are an extra wrinkle in all of this. They are more transmissible. So, but again, the mechanism is important. If it's more transmissible because the infected person is shedding virus longer, then the best way to do that is to avoid coming into contact with infected people. It's not like you yourself are more at risk on a per exposure basis. It's the number of exposures may increase. So, it's difficult. Everyone has to formulate their own opinions based as much evidence as possible as to what they think is safe for them individually. And after vaccination, you're very strongly protected. So it is appropriate to reduce the restrictions on your behavior without going crazy. I mean, I wouldn't be going to Miami Beach and whooping it up with 25-year-old kids. Well, kind of wouldn't be doing that anyway, but
Okay.
you see what's been going on and you go, what planet are you living on? There's some shockingly poor behavior in the States still. So everyone has to act responsibly and based on the best personal judgment of their risk tolerance level. Some people don't get out of bed in the morning. Some people go to work. It's different.
Okay. What do you think about flying on a plane if you're fully vaccinated?
It's generally considered safe if you mask up, and people have been flying on planes for the past 6 months or so, and travel is picking up. It's rightly mandated that you wear a mask. If you're fully vaccinated, you're probably pretty safe. Again, why are you traveling? I mean, it's one of those, you have to ask yourself, is my journey strictly necessary? Because you've also got to pass through airports, etc. If you have an important reason to travel, it's different. If you were traveling for fun, you might want to think about it. It's again depends on your personal tolerance of risk.
Okay. Rather than making variant-specific vaccines, shouldn't the manufacturer make pan vaccines?
Well, yes, if possible. There are flu vaccine programs been going for the best part of a decade to make a pan-influenza virus. It's not proven possible. Now, it doesn't mean it's not possible, but it does say it's not easy. So yes, there will be efforts to make pan-reactive vaccines, but don't expect an instant answer.
Okay. So the next question, mild and moderate disease can cause long COVID. Also, new variants can arise from mild and moderate cases. So shouldn't we be concerned that Johnson & Johnson does not prevent as many mild and moderate cases?
Yeah, I mean, it's a good point. I mean, this is where we kind of tread on eggshells, because the official policy is to take whatever vaccine you're offered, because the most important dynamic is to stop people getting severely sick and dying. And yet there will be more people who do become infected after taking J&J, and the severity would be reduced in all probability compared to what you had without vaccination. But it is certainly going to be possible that some people will go on to long COVID because we understand so little about the dynamics. Whether anything can be done about that, I don't know. I don't make policy. But it is an interesting point, and it's the one that shouldn't just be dismissed.
Well, I have a question. So Pfizer and Moderna, they claim 95% efficacy, but what age group was that studied in?
Across all age groups.
Across all age
Pfizer and Moderna data, and again, Israeli real world data and British real world data suggest that Pfizer and Moderna are effective across all age groups. The immunogenicity levels, antibody responses in people over 65 were down less than twofold compared to younger people, which needed to be done and was done last summer and was a good result.
Okay. Could you talk a little bit more about one-dose regimens for people who have already had COVID-19? Should someone who's had COVID hold off the second dose of Moderna or Pfizer?
Well, as I said earlier, right at the start of this, FDA is looking at this. There's a lot of data emerged. Some of the first studies were very Spartan, but the studies have increased in quality and quantity over time. And they all say that one dose to convalescence boosts your antibody response up to a very high level. And the FDA is looking at whether we can recommend to not have to take the second dose. At the moment, the FDA recommendation is for the second dose, and there's no reason not to get your second dose. It can give additional short-term side effects, but while the FDA recommends it, I would personally do it, but I anticipate the FDA relaxing that procedure.
So here's a question. If I've decided to forego a vaccine in favor of natural immunity, in light of my low risk status, healthy, normal range, body weight, I'm young, would you find this reasonable?
Personally, no, I wouldn't trust it. I mean, there's been plenty of examples of people getting infected while young, and they go on to severe disease and death. It's rare compared to older people, we all know that, but it's not zero. And there is no such thing as natural immunity against viruses. You come across one, you'll at some point you'll get infected. I mean, yeah, people's susceptibilities to infections vary. I very rarely get a cold. I don't get flu very often. And other people, we all know people who every time a bug goes around, they get infected. But we don't understand the dynamics of that. We don't understand the genetics of that. And no individual could possibly know that they're going to be resistant to coronavirus. So I personally would not take that risk. I would be vaccinated as soon as I'm eligible to do it, whatever age range I was in.
Yes, I know several people who have gotten very ill who told me that they never get ill, they never get sick, never get the flu, and they have COVID.
It's a different virus.
No. Can you discuss where we are with getting children vaccines? Do you think vaccines will be authorized for people under age 16 by the time the next school year starts in September?
I hope so. Vaccine trials are ongoing now in children, and rightly so. I mean, look, the standard practice, and it's the correct practice, is you prove safety and efficacy in adults, because children are considered more vulnerable population, and obviously they are. So once we've got vaccines that work in adults, you open it up to children, and I would imagine very strongly they'll be as safe and effective in children as they are in adults. So we're going through a process. In the States, we do things, the FDA does things in a very deliberate way, which is the basis of public confidence in the process. And you can make arguments to speed things up, and we could have started a while back, but this is where we are. I'm sure the vaccines will work in kids. I'm sure they'll get approved. As to when, I would hope that we would be talking about getting them approved and rolled out by the start of next school year. I really hope so, because the kids and their parents badly need this.
So countries in Europe are going under lockdown. I know Italy, France, others. And is that mainly due to the lack of vaccines? And also, are we at risk of going under lockdown again?
I don't think so. We're talking about chasing after new variants.
Right.
The rate. Well, no, I don't think we're going to go into lockdowns again. I think the vaccines, if enough people get vaccinated, and there's still a problem with vaccine hesitancy, particularly among Republican leading voters, where a very high fraction of them, 30, 40%, are going to refuse to take the vaccine. And that is as big an obstacle to ending the pandemic as anything else. I mean, vaccine hesitancy in a large fraction of America is going to be a big problem. So, I don't think the variants are going to cause the vaccines to crash and burn. And I think it's prudent to plan for redesigns or additional boosts. All of these things make sense, and we have the time now, unlike a year ago. We have the ability to plan, and plans started months ago. So if we need a plan B, I think we'll have a plan B, but I'm not panicking about variants. I'm concerned about them, but again, they're not variants of mass panic, and they shouldn't stop how we behave as long as we continue to behave with common sense.
Okay. So I'm just going to skip a little bit. Someone's asking, I was vaccinated 2 weeks ago. I have the Moderna vaccine. I'm flying to LA on Friday. I will be staying with my daughter who just had her first vaccine. I'll be staying in her house. So should we both wear masks and socially distance as well?
I may have missed some. I got the question. I was vaccinated over 2 weeks ago. Well, vaccinated by the first dose or the second dose. I mean, if you received your second dose 2 weeks ago, then you're pretty strongly protected. And you're staying with a daughter who had the first dose. Well, you're not at risk because you're vaccinated. And your daughter's not really at risk from you because you're not likely to be infected. So you're probably pretty safe, mingling with your daughter indoors.
Okay. So do you think we'll constantly be chasing after new variants? It seems like an endless race.
Yeah, that's the one that I just answered, I think.
Okay, you did. Okay, all right. We've been repeatedly told that children don't drive this pandemic, and that infections in children mirror the prevalence in the community. Is this still going to be true with the new, more transmissible variants?
Yeah, it's an interesting question. There are anecdotal reports that children are more at risk with the more transmissible variants. That there's no papers on this. There's no published data. There's just this scuttlebutt that more kids are getting infected recently than in previous months may reflect an influence of the variants, but it's not hard data yet. It's going to be looked at.
Okay, so next question. I heard Moderna was trying to lower the amount of mRNA from 100
Yeah.
100? Okay, can you talk about that? Is that okay?
So, when Moderna and Pfizer had to develop their programs in a hurry, as they didn't have the time to do the detailed dose ranging studies that you would normally do. And they made educated guesses and as to the dose. And Moderna went for 100 and Pfizer went for 30. And it's now sort of kind of seen that Moderna has a bit of overkill in that. Wrong word, that they're just using more than necessary. So recently, Moderna did a phase 1 immunogenicity study with 100 and 50 in comparison, and they were virtually identical responses. So there's now an argument that they can cut the dose from 100 to 50, which sounds easy, but in practice, it's not because of how the vials are formulated, because it makes it not easy to measure out accurately half the amount. It's already a small volume. And it becomes a question of whether you get the volume into the right graded part of the syringe, and it's all very technical. But the half dose would almost certainly work as well, and it's going to get looked at or going to get reformulated vials. The Pfizer 30 micrograms seems about right, and I don't think anyone's going to mess with that.
Okay. The next question, why don't you take a look, because it's kind of long.
Yeah.
Let's see.
Well, if you're not infected, you're not transmitting it to other people because you're not infected. So if the vaccine is preventing you from being infected at all, which I answered earlier, is starting to look more and more like it is, you're not transmitting to someone else. So that's the simple answer. But, it is a complicated question. I'm not sure I got to the end of it, but yeah.
Okay. Are there any behaviors, such as using drugs or alcohol, for example, that can reduce the effectiveness of COVID vaccinations?
Or any immunosuppressive drugs. If you're on any form of immunosuppressive drug, or if you're an immunosuppressed individual, and some cancer patients are being looked at in this regard. So anything that you know or have reason to believe is a genuine immunosuppressant. Drugs and alcohol, not really. The Russians did a lot of sort of interesting stuff over the past year in their program, and Putin is now getting vaccinated and is refusing to say what vaccine he's getting, which is a bit of a tell. But they issued an announcement at one stage asking people in the Sputnik V vaccine trial to refrain from alcohol for a period of a week or so after the vaccination, which in Russia is a massive hardship given the vodka habits. And we kind of giggled at that because it was, where's the evidence that that makes a difference? And then we thought, well, okay, and drinking industrial quantities of vodka might have an impact. But the simple answer is probably not, but everything in moderation. I mean, I wouldn't go out and get vaccinated and then go out and get blasted in a bar. I mean, so you have to, again, behave sensibly. I mean,
So
amounts of alcohol are never a good thing for your health.
So some people, there's a lot of circulation about that before the vaccine, you shouldn't take Motrin or Advil.
I don't think so. I've seen one paper on whether or not these, over-the-counter NSAIDs are an impact on immune responses in COVID. And I was greatly relieved to find that ibuprofen was not on the disapproved list because I crunch industrial quantities of it after every cricket match. So, it enables me to get out of bed in the morning without a pulley and a winch. But yeah, they're over-the-counter NSAIDs. They're very mildly immunosuppressive. I wouldn't be concerned about it. But if you feel, if you don't need to take it, don't take it. But I wouldn't be panicking over just because I had a Motrin or something the day before a vaccination. That's highly unlikely to cause a problem. And
Tylenol is fine because it's not anti-inflammatory.
Yeah, sure. Yeah. The NSAID thing in COVID, if I'm remembering it correctly, I mean, they reduce cytokines. They were better taken later in COVID, but not early. But again, these are sort of seem to be fairly heroic doses, and it wasn't a terribly convincing study. It's a sort of a cross between something that's a little bit true and an urban legend.
Yeah. I mean, a friend of mine who's a rheumatologist said that baby aspirins are fine because they don't have anti-inflammatory properties. Yeah. So I kind of know what you're going to say. What do you think of state easing restrictions, more allowance of indoor restaurant dining?
Well, the problem with this kind of question for me is they're really aimed at public health specialists. And, I'm a vaccine and virus guy. I just resort to common sense in that situation. Behave with common sense and use your judgment.
So I'm pretty pleased with it that there's so many people more people getting vaccinated now in the United States. It's really great. And I just wish that people, like I went to an outdoor restaurant last night and they were just packed with people. And I'm thinking, how safe is this? But
again, I mean, I'm going on Saturday to leaving dinner for a guy I've known for years who's moving from our cricket club to the West to Texas. And it's going to be outdoors and I'm comfortable and we're all going to wear masks except when eating. And I'm comfortable with that. And I'm not vaccinated. But I'm willing to take a sensible risk in an outdoor setting, and that's my choice. So please compare protection from prior infection. That's actually an interesting question because there were 2 papers came out last week.
Mhm.
One from the Cleveland Clinic and one from Denmark, and which has another one of those massive national health systems and collates huge amount of information from an entire country. And they both looked at protection from reinfection last year. So the study started in March and ended around September. So, you know, it was pre-variants, and it measured the degree of protection against reinfection over that time period, and it was around 80% in both studies. It's almost identical number in both studies, which gives you confidence. So that's on a par with, but actually a bit below vaccination. So you can get reinfected, 20% chance, at least last year. But generally, the second infection was even milder than the first. So it's you know, it's not a biggest of big deals. There are a few examples of South African and Brazil variant reinfections. In fact, in Brazil, there are a lot of examples of Brazil variant reinfections. It's actually becoming a real problem. But there are a few examples in the States of reinfections by Brazil or South African variants and in Europe, and they can be quite nasty. So if you do get reinfected, there can be, but not always are, quite nasty.
So here's a question I have. So some people are bragging that when they got the second vaccine, they got a really bad reaction and that therefore it was more effective. I got a mild reaction. Paul Offit told me he really didn't feel good afterwards, but he said it doesn't make a difference.
Make a difference. It's been looked at. There is no correlation between the antigenicity and the antibody response.
Okay. I think you answered this question. Okay. Do you see the US getting to herd immunity before at least some proportion of children are immunized, especially given the vaccine hesitant adults?
That's what I mentioned. That
yeah, you said that.
A large fraction of Americans who refuse to be vaccinated for, you know, and there's different categories of this. Some are because they still don't believe that COVID exists. They won't wear a mask for the same reason. It's, you know, it's pure republicanism, scary stuff, QAnon, tinfoil hat brigade people. I mean, there's nothing you can, there's nothing you can do about this. I mean, my personal solution to that would be to introduce vaccine passports that prevent you getting on a flight or going to NASCAR or going to the movies if you're not vaccinated. And if the companies did that and not the federal government, then you don't have to get vaccinated. But if you want to travel from California to New York, rent a car. You know, that's my sort of anti-civil libertarian attitude to the problem. But it can be and may well be a very significant issue in achieving herd immunity if, you know, 30% of 40% of a large number of people refuse to be vaccinated.
Well, when there was a measles outbreak, it was driven by people in the left in California.
Yeah, sure. It's not all Republicans, but
no.
Only around 10% of Democrat voters are declining to be vaccinated. It's something about 40 to 50% of Republicans. I mean, different surveys. So yeah, there are people on the left who refuse to be vaccinated because I don't want to put anything in my body that hasn't natural. I don't trust the pharmaceutical industry. I've heard it's got mercury in it. It gives me autism. All of the old tropes are floating around. I mean, they're not going to change. And, you know, those people are also very difficult to persuade to change their ingrained attitude. But, you know, people who are just insecure, hesitant, unsure, are open for reasoned conversations, having a sensible discussion, providing the facts, power of persuasion. I've done a number of these within the college, outside the college, and if people are willing to listen and have open minds, then it's a matter of providing accurate information. But the zealots, it's just a different ballgame. It's not persuadable. So there are different categories of refusals. It's the same with masks. You know, people refuse to wear masks because it covers God's graven image. Well, you know, next time you're on a plane and the oxygen levels drop, are you going to refuse to wear the oxygen mask because it covers God's graven image? I mean, it just doesn't make sense, a lot of this stuff.
Yeah. Well, I'll tell you one story. My daughter's father-in-law is very anti-vaccine, wouldn't get it. And then his son got his granddaughter and said, Grandpa, I love you. Can you please get the vaccine so you can visit me? And
Sure.
he melted and he got the vaccine. So, yeah,
Power of persuasion,
yeah,
if you have the ability to do it on a one-on-one basis, that's very powerful. But there are some people you just can't get through to. It's just I used to have this with groups of people who didn't believe that HIV causes AIDS, and
yes, yeah.
you can't persuade them that they're wrong because they're tinfoil hat brigade.
It caused a lot of problems in South Africa, I think, and other
Absolutely,
places.
they did.
Yeah. A person got infected a week after the first dose. When do you think this person should get the second dose?
Well, the first priority is you can't expose the vaccine provider to any risk of being infected. So you absolutely have to recover. Um, it's the CDC guidelines for the period of recovery. I think it's 90 days from the recovering, or 90 days from infection to second dose. I think that's it. And of course, getting vaccinated and infected, one is kind of boosting the other, but a little bit early. It's tricky there. I'd give it some time. Certainly I'd look at the CDC guidelines, which I think are 90 days. And you're not going to be much risk of getting reinfected within that period. I mean, the combination is such that you've got two levels of protection, one infection and two vaccination. If it had been 3 weeks after the first dose, I'd have said you don't need it at all, but it's a tricky one, but give it some time.
Now, I have a friend who got COVID, but then he got vaccinated 2 weeks later. So I guess that's not in the guidelines.
Yeah, and there are these cases. And, talk to your physician is another good thing, and hope that he or she is well up on the science.
Okay. But I think when I read that question, I was wondering, I thought they were asking, should the person who has COVID speed up the second dose? And that wouldn't be a good idea either. No.
I don't
Okay.
think so.
Yeah, okay. What protection do T cells and other immune responses offer besides NABs against the variants?
Neutralizing antibodies.
Right.
But we have T cell immunity for a reason. It's good. We wouldn't want to not have it. The correlate of protection for these vaccines is increasing mountain of evidence that it's neutralizing antibodies. There's plenty of studies along these lines. T cells generally protect against disease. So antibodies generally protect against infection and limit disease. T cells are protections against disease. So the T cell responses to these vaccines has been studied. It clearly exists. It differs between vaccines to an extent. It's there. Regard it as a bonus. But I think a T cell only vaccine, if one was made, I wouldn't want to rely on it unless something very surprising happened in the immunogenicity studies.
Okay, is it valid to calculate herd immunity based on the prevalence of both vaccination and disease?
It's very commonly done, and I think it's reasonable to do that because in both cases, you're relatively resistant to reinfection. So I think it's reasonable to do that. And then the numbers of recovered convalescents plus the numbers of infected people starts to get you into a high percentage.
Okay, I had another write-in question. Do the variants impact young people at a higher rate?
Well, a higher rate than the original strains. Well, I sort of answered that only anecdotally. There's, scuttlebutt, grapevine reports that kids might be getting infected more often than was previously the case, but there's nothing on it in terms of data.
So is there anything that you wish you really knew that you don't know now, that you had an answer? What would you like to have? What would you like to have an answer to right now?
Is there anything I would?
Is there anything that's unknown, like how long does the vaccines last? Is there anything that you would love to know right now?
Well, yeah, the longevity issue, because you can only work out how long something lasts by looking at it for a long period of time. You can only extrapolate. Last year there were waves of papers saying the antibody response to infection is declining really rapidly. It's going to fall off the charts. We're all doomed. And, they were misinterpretations of a natural phenomenon. Firstly, immunological memory kicks in. It does exist and it's there. And secondly, antibody titers tend to go down very rapidly and then turn into a second phase where it becomes more gradual. And there are papers now looking at antibody responses in infected people over 8 months, and they're still present in most people at decent levels. There are declines, but your immunological memory is also there. Vaccines, data out 3 months, 4 months says the antibody responses are still fairly high. They're declining. We don't know whether efficacy will also decline. It may be more of a problem with J&J's 1 dose, and in which case you have a second dose. I mean, the company is doing a 2-dose trial, and I think it's doing that for a reason. And those results will be available in the next several months, and it may convert to a 2-dose vaccine. I'm speculating. That's not policy. So it's possible.
So,
yeah, I'd love to know what will happen in 6 months' time, but then, I'd love to be able to predict who's going to win various sports competitions and bet on them.
okay. I think we all would. So you don't think the AstraZeneca vaccine will get approved in the United States? We talked about that before we came on.
I think it may get approved. I mean, it's got such a lot of controversy. I mean, this latest ridiculous fight between the Data Safety Monitoring Board and the company is both unprecedented and truly bizarre. I mean, late night calls to the White House, issue a press release at 12:30 in the morning. I mean, this is crazy land. Yesterday was just among, typically insane COVID day for people in my field. And it's a storm, and it's argument over next to nothing. It's whether or not the efficacy was 79% or 69%, which is frankly a distinction without a difference, but seems to matter to the company PR people. So, that's a lot of politics involved in that. The FDA will review the data as the data. It's not, I mean, the people on it, some of them I know, they're people of high integrity. They're not going to be swayed by controversies. They'll look at the data when it's filed with them. It hasn't been filed yet. And they may approve it. If the data says it's safe and effective, they'll approve it. The question of whether it will be used in America is another question entirely. Because if it, with hesitant, nervous fractions of the population, this is a vaccine with a lot of controversy attached to it now. The European scares in the past month about brain bleeds, the neurological complications in clinical trials, the mess up in the British clinical trial design. Okay, that's more sort of, for nerdy rather than, and for the scientific people rather than the public. But this latest controversy is yet more column inches. It absolutely ticked off federal officials. Key opinion leaders are not happy about it. You can sense in the media, newspaper reports, they're basically going, what's going on? It's got a black spot against it, this vaccine. So the question then is, does the USA need it? And projections are there are going to be enough of the 3 approved vaccines plus Novavax available that we don't need the AstraZeneca vaccine. So if we don't need it and it's too controversial, what's the point of trying to persuade the public to use it? It is better, in my opinion, to donate it to countries that do want it and do not have alternatives. And there's been a number of opinion pieces and planted newspaper stories about this in recent weeks. And that is an interesting perspective. And there's now a loan program being put in place for Canada and Mexico, and they seem to want it. And if they want it, and it's a stock that's not going to be used, they absolutely should have it. And I'd like to see more stocks being given to the international COVAX community, of getting vaccines into developing countries that literally do not have an alternative. Because it's not that the vaccine doesn't work. Even at 65% efficacy, it works, and greater than that at reducing disease. It's a lot of it is about perception now. So I'd rather see it used where it's wanted and not risk annoying the public or creating more controversy in a way that's avoidable. We could loan it to Britain and maybe get some Scotch eggs and English wine back.
Okay. Do you think the AstraZeneca vaccine causes clots or just a coincidence?
Well, I'm not a physician. I don't study this in detail. The European Medical Agency, which is the equivalent of the FDA, cleared it last week after an investigation. Now, so you have to assume that they did that for a reason and that it's being cleared. But for sure, the FDA will be looking at the data filing on safety. I mean, the FDA reviews safety and efficacy, and it will probably spend more time on safety than efficacy. So it'll be interesting to see what the FDA receives and what the FDA thinks.
I'm very heartened to see how the FDA and CDC have gone, their stock has gone up. They're more trusted now, I think, since Mr. Biden has taken office.
Yeah, the people in my world at times, if you try and do anything in clinical trials with the FDA rules can be so pernickety at times. I mean, they can drive you nuts. But in a time of national emergency where it's important to get public confidence up, a major difference between what happens here and in the UK is the FDA advisory meetings are open. They're transparent. You can go in, you can zoom in, you can attend in person in a normal times. You can see the sausage being made. In Britain, it's all done behind closed doors, and you can't see the discussion. And that's proving to be a bad move in a pandemic, because you get public confidence up by inviting the public to share in the process if they choose to.
I've been to FDA advisory hearings, and the majority of attendees are stockbrokers.
Well, yeah, I mean, there's a certain amount of that. They want to know whether to invest in something or not.
So anyway, I want to thank you for your time. Before I end the program, I want to say next week, March 31st, we're going to speak to Abito Habusha. She's Vice President of the New York State Health Foundation. And we're going to talk about food scarcity and the lack of food in the United States. Pretty shocking, actually. On Wednesday, April 14th, we're going to speak to Helen Fisher, and we're going to do a redo of the dating of the pandemic 1 year later. And then on Thursday, April 22nd, Liz Lee Heineke has written a book about Madame Curie called Radiant, and I'm going to interview her. So, Dr. Moore, it's always a pleasure to see you. You're close by, so we can meet one day in a park or something. Anyway, wonderful to see you, and thank you so much for being so generous with your time.
A pleasure. Always happy to help out. You guys run a great group.
Okay, thanks very much. Everyone out there, stay safe and tune in next week to discuss food scarcity.
All of you stay safe.
Okay, take care.